Okay, good morning, everybody. Now, this is the first time we have done Ettinger Club or rounds with the new Ettinger. Did everybody get excited?
Yeah, it's so cool.
Oh, yeah.
I came in the post, I was like, oh my God.
Yeah, I ran
Nobody else
around being like, it's
understands.
here, it's here.
Yeah.
That's actually so good. And heaps of information and stuff in there, heaps of updates. So well worth the investment.
Yeah, I
What
actually gifted myself the new Ettinger.
did
Yeah,
you? Well
good.
I'm so
done.
excited. Yeah.
Yes, yeah. So I feel like I'm amongst my people getting excited about Angel. Nobody in my family appreciated it.
I wonder why.
And so weird. Marine engineer, who'd know? So the topics that we're covering today are dyspnea, tachypnoea, and respiratory distress, and syncope. And Josh is going to cover syncope, and I'm going to do the respiratory side of things. I made Josh do syncope because he said it was outside his comfort zone. So everybody asked him really hard questions.
Yeah, I think my weakest point is definitely hearts, because I've been spoiled with cardiologists all the time and Anna all the time. So I've had to, I outsource a lot of my heart stuff, which is good for me, but harder when I have to actually do it myself.
Yeah. And we do have somebody new with us today.
Hello.
Hello.
Hi there. I'm Jalal. Nice to meet you guys.
Jalal, very nice to meet you too.
Hi.
So just to give you a sense of comfort, I asked Josh a lot of questions because he's my old resident.
Sure. No
Given
worries.
me consent to ask questions. We won't drill you unless you want to be asked questions if you're sort of practicing for exams or anything like that.
Yeah, no worries. Yeah, I'm studying for memberships in small animal medicine this year,
Awesome.
and I'm doing an ophthalmology internship currently up in Brisbane. So yeah, I've been listening to you guys on YouTube for a bit and really enjoying it.
Excellent.
Yeah.
So you know,
cool, awesome.
You know the drill. If you do want to, like, it's open, like, just chuck out questions.
Sure.
Go, much rather make it interactive. If you do have any specific questions. As we get closer to exams, we'll start formatting it more in an exam kind of format. And if people want to participate in being asked questions, then we'll get their consent and start throwing stuff at them.
No worries.
Awesome. But we'll let you coast because it's your first day.
Cool. Yeah, no, thank you.
All right, do you want to start, Josh?
Yeah, sure.
Yeah, cool.
Cool. So yeah, syncope, I thought it was a pretty good kind of overview chapter. Didn't go too in depth with any of the, I guess, all the diseases that can link or cause syncope or non-syncopal signs, but I think it's a good overview just to kind of get an idea of how you approach a case with syncope, as well as what you should be kind of thinking of. So yeah, I did like this chapter. As always, they kind of start with a pretty good definition, I thought, because whenever I think about it, I'm always like, well, I think of syncope as, loss of consciousness, but I always found it kind of hard to differentiate between like non-cardiogenic, like neurocardiogenic, and cardiogenic syncope, because they kind of seem like the same thing to me, like in a lot of ways. But so the definition in the book is it's a subset of collapse that involves a transient loss of consciousness resulting from insufficient blood flow to the brain. So that's the kind of clear definition. You can get pre-syncope as well, which is another term that's kind of thrown around, which is kind of when you have the things that cause syncope kind of half getting there and they often get a bit wobbly or become weak, which we can see as well. So when we have syncope on our list of possible clinical signs of when animals are coming into the building, it can be it's super important, obviously, that we need to try and decide whether it's syncope or whether it's not. Non-syncopal collapse episodes. And that can be really hard because, to be honest, in referral practice, we don't really get a lot of referral we don't get a lot of cases coming in as like a first presenting case or collapse like that. Often it's been through emergency or it's seen a primary care vet and they've kind of figured out what that is. So the hardest job is already done for me, thankfully. But trying to figure out, because often if they have syncope, sometimes they completely, well, most of the time, one of the defining things is they completely return to normal very quickly. So they can come into your consult room looking completely normal, and that makes it really tricky. So, but then at that time, we're looking for clues. So things like raging heart murmurs, arrhythmias, those kinds of things that might give us a bit more of a clue, or any kind of seizure clues. So, you know, really high CK or hypothermic or post-ictal, those kinds of things. So the two kind of ways they broke up syncope here was cardiogenic syncope and non-cardiogenic, neurocardiogenic syncope, very clear. Cardiogenic syncope, the difference here is that, well, does anyone know the difference?
Well, neurocardiogenic would be probably mediated by what the parasympathetic or sympathetic systems, I guess. And cardiogenic's probably inherent within the heart muscle itself. Would that be right?
Pretty much, yeah. So yeah, neurocardiogenic definitely to do with the sympathetic, parasympathetic nervous system. So it's generally associated with increased vagal tone. So you might have heard like a vasovagal syncope, which is the way I've heard of it. I think there are other terms for it too. But it's more associated with a reflex in that you have an increased vagal parasympathetic tone, which then causes bradycardia and a reflex vasodilation. So you get a net kind of hypotension very quickly that then causes decreased blood flow to the brain.
Can we just throw in there, vasovagal episodes will have quite a distinctive history because they're to do with increased vagal tone often. So what in the history might kind of give you a clue that this might be a vasovagal cause of syncope?
Maybe if there's chronic respiratory disease, or
Right.
they're who.
Yeah. And in the sort of immediate, like immediately preceding the syncopal event history, anything that you can think of that might trigger an increase in vagal tone or an acute increase in vagal tone?
Like coughing, sneezing, like these sort of things, coughing and...
Yes. Yeah. The most often cough induced, sometimes vomiting or gastrointestinal signs.
And sneezing, apparently. I haven't seen that before, but it was in the book.
Yeah. That's an impressive sneeze.
Mm.
Can you
Do you
imagine?
have
Like take a dad sneeze.
Yeah.
high vagal tone before that? Like, do you have to have a predisposition, or can any healthy animal have a vasovagal episode?
See, I've never seen it in a healthy dog. I think I've only ever seen it. I've seen it once in a vomiting dog. Every time he vomited, he fainted. And by far the most common thing is coughing that precedes or sort of exertion. But I think that's then falls into maybe pulmonary hypertension kind of category or hypoxemia maybe.
What about excitement, like severe excitement?
Yeah, for sure.
Is that
So-
vasovagal though?
It's under the neurocardiogenic causes of syncope. They talk about boxer dogs in like 1930 or something, in a study in 1930 by someone, I don't remember the name, it's probably in the book that I've left at work, but it's so that's also a good kind of historical clue. If they were suddenly really excited for some reason, had a collapse episode, returned completely to normal, then syncope and neurocardiogenic syncope would be kind of higher on the list.
It must be so hard to differentiate like cataplexy in that situation.
It's they talk about
Very much
cataplexy and narcolepsy and that kind of stuff. Like
Yeah.
you can't, it's really hard to differentiate. And I found as well that so much of the neurocardiogenic stuff kind of does just blend over into cardiogenic as well. So, I mean, it's all kind of the same, but I think it helps. You just need to be thinking of other causes and other systemic disease.
Yeah.
That's what I took away from it.
Yeah.
So neurocardiogenic syncope can also be associated with cardiac disease as well, which is where it gets a bit complicated. And also it's associated with gastrointestinal disease as well. So that can increase vagal tone and kind of predispose them to that potentially.
Any breed predispositions, Josh?
Nothing that, unless I missed it in the textbook and anyone else saw it, but I didn't note anything apart from the boxes that were mentioned.
Oh, yeah, that's what.
Yeah. An interesting one that definitely is one that I know my supervisor would love to know. He loves like named things, I find, which is the Bezold-Yarich reflex. Do you guys know what that is?
I did once.
Yeah, I didn't know it, but yeah, I feel like yeah, it's so essentially it's most often associated with heart disease or anything that's basically increasing your ventricular pressure. So aortic outflow issues or like hypertrophic obstructive cardiomyopathies. And I think the idea there is, correct me if I'm wrong, guys, but the increased pressure triggers some receptors in the wall, which then tell the brain to basically try to counteract that. And as a result, you get that reflex where there's bradycardia as well as a reflex vasodilation. So yeah, it inhibits the sympathetic outflow. So that can be with cardiac disease, which I think is really confusing because it blends over into cardiogenic syncope, I feel, but it's technically a neurogenic reflex. And as well with acute hemorrhage. So when they lose so much blood suddenly and cardiac output is decreasing rapidly, the heart starts to try and kind of flutter to increase that output and increases that pressure on those receptors as well, and you can get that reflex. And that's the Bezold-Yarich reflex.
Mechanistically, this is a really interesting reflex because we used to say anyone that's treated tick paralysis 20 years ago, we used to say that there was two types of reactions to tick serum, particularly in cats. There was this Bezold-Yarich, the BJ reflex, or anaphylaxis. And with the BJ reflex, the heart rate goes down. With anaphylaxis, the heart rate goes up. Does anyone remember that? Yeah. So they now don't think that reaction actually happens in response to tick serum. It's a volume change. So all of a sudden you're like giving a bolus IV to a cat, which might be 10 mils or something like that, which ultimately overloads the ventricle and increases outflow pressure and causes this kind of drop in heart rate and profound hypotension.
Wow. Yeah.
And then similarly, cats, you know how we talk about how you shouldn't drain a large volume peritoneal effusion in a cat? So if you drain the whole effusion and you decrease pressure on the splanchnic vessels, and the splanchnic vessels then acutely dilate, it acutely decreases venous return to the right side of the heart. And then you get this same like massive drop in heart rate. And I think they call it suicide ventricle in cats. Their heart can just stop. So yeah, there's interesting kind of, this reflex is, again, there's a lot of crossover between other kind of definitions and situations. Sorry, Josh.
No, that's super interesting. It's awesome. That's what we're here for. So that's neurocardiogenic syncope. Cardiogenic syncope. So that's, as Jeff said, it's more to do with the heart. So basically the heart dysfunctioning, leading to a decrease in blood pressure and then therefore blood getting to the brain. What I guess is the main things that would cause a decrease in blood pressure or decrease in heart function in dogs and cats.
Arrhythmias and valvular disease.
Oh, good, Brian. Yeah, arrhythmias. So definitely arrhythmias are, I think, the biggest. So yeah, bradycardias and tachyarrhythmias as well. Anything that can really inhibit the cardiac output because of the rate, essentially, or the function of the heart is probably a really big one to consider. So bradyarrhythmias can be things like heart block, again, probably a big one, or any kind of sinus arrest as well. So yeah, essentially with that kind of way, we're going to have a reduce in cardiac output and therefore hypotension, especially depending on how severe that heart block is. So it's more severe ones where the heart stops basically. Whereas tachyarrhythmias, so things like ventricular tachycardia, we're going to have an inefficient heart essentially, because it's just trying to, its cardiac output is just so terrible because it can't potentially do a proper contraction to pump out that blood. So we have a decrease in blood pressure. There also can be combinations as well. So combinations of structural issues as well as an arrhythmia. So if you have like a really mild arrhythmia, like a supraventricular tachycardia, that's not really going to cause syncope, then if this, the heart is also structurally abnormal, then potentially that would add to that as well.
What about pulmonary hypertension? That's a big one.
Yeah, so in that, I think, so if there is pulmonary hypertension as well, then it's probably going to add to that too. Pulmonary hypertension also, they noted under neurocardiogenic as well. So it sounds like it's just kind of in and amongst all of it. And
Is it because pulmonary hypertension itself is like 6 classes?
Yeah,
So it depends on why you get the pulmonary hypertension. Is that why that would be?
Anna, do you know?
I think there's just so many mechanisms of syncope with pulmonary hypertension. So often we've got hypoxemia, which can cause syncope. We've got that increase in pressure to cardiac outflow, which can cause that almost like the BJ reflex, not so much with a hypotension, but with a massive slowing down of the heart rate. We've got coughing often as well. So we've got increased vagal tone from increased respiratory stimulation. So there's just a lot of ways that it might make an animal pass out.
Cool. All right. So that's our syncope. I've got some cool, Ettinger has some cool videos. So I'll show a couple just to cut before we go into diagnostics quickly. But what are some non-syncopal causes of collapse that we want to try and differentiate from?
Seizures, perhaps, but they don't have consciousness.
Yeah, but definitely to an owner, they sometimes can't really tell the difference. So yeah, definitely seizures. That's probably the biggest one, I'd say.
And I think it's important to sort of say that if syncope, if the brain is hypoxic for a prolonged period as a result of syncope, it will turn into a seizure and it will look exactly like a seizure. So it can be really hard to differentiate them regardless of what the etiology is.
What about paroxysmal disorders? Like, would that?
So that's awesome. Yeah, great. Perfect. I always forget about those.
And
so movement disorders, definitely.
Border collie collapse or Labrador retriever collapse can look like syncope.
Good.
Yeah, absolutely.
Hypoglycemia as well, or metabolic disorders.
Excellent.
What I didn't know is, yes, I guess with the book was talking about hypoadrenocorticism as a potential cause for syncope. Is that something that is common, and what's the mechanism behind it?
What if it's like a hypovolemia?
Okay, got it. Yeah.
Is that what your thought would be, Anna?
Or hypoglycemia, although I've never actually seen a dog clinical for hypoglycemia with Addison's. It's kind of a theory.
Yeah. Okay.
But yeah, any kind of hypoxemia causes, so like upper airway obstructions as well,
Mhm.
can look like, or can be another cause of collapse that is not cardiogenic or neurocardiogenic syncope.
Mm.
Josh, the Border Collie and Labrador collapse you're talking about, I can't think of the name of it. There's a condition in pigs with halothermic anesthesia that
Oh,
reverses-
malignant hypothermia.
Mm.
Yeah,
Happens in greyhounds too.
Greyhounds too,
Yeah.
yeah.
Mm.
is that what you're talking about? Or is that
I
different?
think it's more, isn't it an exercise induced?
Yeah,
Yeah.
that's different. It's
Yeah.
quite
Upset.
like a exercise, and it's a combination of exercise and intense focus. Like generally has to be a ball involved or a competition.
Mm. It's
Yeah.
got a genetic component too because it's familial.
Yeah. There's also gluten diet now responsive collapse.
Yeah.
Oh yeah,
They have isolated a gene or they are
Border
looking into it.
terriers or
In
something?
border collies, I think
Yeah.
it is.
Yeah.
border, yeah,
Border
border.
terriers, I think.
Cool.
Mm. Or
Awesome.
weekends. Never mind. We'll go get to that when we do. I remember there's something I'm supposed to remember about Wheaten terriers and wheat. Like they've got some gluten, but I can't. That's how I remembered it. But obviously, can't remember what it is.
That's great. So let's look at some videos quickly, and then we'll go through diagnostics in a couple of minutes. How do I do that?
Oh,
Different.
have you got the videos open on your computer?
Can they see? Everyone see this?
Mm-hmm.
Yeah.
Yeah, there's heaps of good videos on here. It's so good. I don't know if they just put
Really
more
good.
in, but it's so good. All right, so this is syncope in a canter. I think it has a heart block.
Mm-hmm.
And some of them are pretty. It just shows the kind of like how much variation there is. This dog just returns completely to normal very quickly, but there's so much variation in syncope.
Good morning.
Yeah, he's like, hey, what happened? What happened?
Mm.
Fine, eh? Then we've got a cat with syncope as well, which is I think this is pre-syncope, sorry. So it's just, you can just see it gets quite wobbly. I had a cat like this recently, so now, and I don't think I really thought too much about syncope because it was done and gone at the time. But I think I might try and get it back for a halter or something like that. This one's interesting because it looks like a seizure. But obviously the owners, you can see there's a halter on the dog, and the owners are very on the ball and know what's kind of going on here. Pretty cool that we've got this trace as well.
Yeah, that's amazing.
You just see suddenly it all just stops. But it can also look like it's got like a pistotonus as well,
Yeah.
which can be really confusing. So yeah, I guess what I took from this is that there's just so much variation.
Yeah. And in this particular video, like the dogs, he jumped up. Like usually seizures, they say that they're resting, but it's still like it very much like so easy to confuse.
Mm.
Yeah, totally. But that's a really good point, Pooja, that they often are resting, and a good part of like our history taking, which is what we're trying to do the most we can.
Mm.
Also, watch with this one to confuse the seizure non-seizure thing.
Whoa.
Wow.
Yeah, pretty full on epistotonus there, and then it urinates. So
Wow.
obviously that's something we often ask, was there any urination defecation? So that can be tricky for us as well.
Mm.
And he's back to normal, just jumps up and wanders off. Or she, I think.
Oh, how embarrassing.
Didn't even know. Anyway, that's all the videos, but I thought they were really good, and definitely thought it was worth watching. How do I now stop sharing?
Thanks, Josh, for these videos. Like, wow.
Oh, don't thank me. Thank Mr. Ettinger.
Doctor.
But you're the middleman, so thank you.
Yeah, well, we've got this great resource, so I think it's worth going through. All right, in a couple of minutes, how would we, if we have a dog coming in with syncope, what are some tests that we would want to do? both little and big, I guess.
Holter monitor.
Even what about even before that?
You want to check electrolytes, calcium, glucose, probably biochem as well.
For sure, definitely.
Narrow things down.
Yeah, absolutely.
That's the rule of specialist medicine. Everything that hits the place gets full biochem
Yeah.
Yeah.
analysis.
So it is lucky.
And then you put the Holter monitor on.
Yeah. So ECG and Holter monitors to try and see if there's especially if we can hear an arrhythmia, we could potentially just do an ECG straight away. But if it's an intermittent arrhythmia or if we're not sure if it's neurocardiogenic, then yeah, Holter monitor is a good thing to also move to. On that note as well, they're also talking about implantable loop recorders, which I've never seen before. I'm not sure if anyone else has seen that. It's a surgical implant of a Holter, essentially. Have you seen that?
Cool. Yeah. They're
Oh, sorry.
really cool.
They're really cool.
I know somebody that's got one just in the chest there.
Human or dog?
A human. Yeah.
We used to use them at North Shore. And it's literally like it's the size of a USB stick, and you make the tiniest incision under sedation and local, and just like open up the subcutaneous space, slot it in, sew it back up again, and then you get the Medtronic people to come and interrogate it.
That's so good.
It's so good. And then the owners have got a little button that they can push when there's an event happening, so that you can say, okay, it's definitely not cardiac, like there's nothing cardiac going on at this time when the dog's collapsed. It was really good. And they say you can leave them in for 6 months.
Yeah, that must be so handy when you're really trying to get tricky ones that you're like, I can't catch it.
That happen over only like once a month or once every 2 months kind of thing.
Like I've had ones where you put a Holter on, you're like, all right, I'm going to do 3 days, and then nothing happens. You're like,
yeah.
So
It's so annoying.
And then you have to have
really
like the cardiologist go through the trace or whatever, and they get the shits because you've made them look at 3 days worth of trace.
Well, the other thing about these monitors is that they like only record when they're irregular, so they kind of like remember, and there's AI that can like send a ping to the owner and say, oh, something's going on now, be prepared. It's pretty cool.
That's awesome. Yeah.
My friend actually works for Medtronic in marketing and sales for Link monitors. I'm really excited for her to come back to Australia and start giving us access.
So we don't have it here right now.
We do actually. I just don't have a connection with Medtronic who I can emotionally manipulate into helping me put them in animals.
I'll have to ask Marika if she uses them.
Yeah, it would be such a good connection to have because they do all the interrogation and stuff as well. Yeah. Anyway, sorry.
All right. Other tests, I guess the other big one would be an echo, just to look for structural heart disease. And then from there, it's really choose your adventure depending on what signs you have that might be neurocardiogenic causes. So if there's respiratory signs, you do x-rays. If there's GIT signs or something there, you do an ultrasound. If you're worried about Addison's, you do a stim. So yeah, but I guess echo and ECG are probably the main, and ECG are the main ones, as well as your kind of preliminary blood testing, looking at metabolic causes of syncope and electrolyte disturbances. And then if everything's normal, definitely have to do a Holter.
Yeah. The one thing I'll just flag, I don't think we talked about on your bloods, just keep an eye on reticulocyte count. Because every now and again, these dogs or cats are having intermittent gastrointestinal or pericardial bleeds, which are causing their collapse episodes, like sudden hypotension. And it can be clinically quite subtle because they're often not coming until the bleed kind of resolves or stops. So if there's a high reticulocyte count, I'd probably like search wide for evidence of bleeding. That's all I have to add.
Cool. So yeah, that's kind of the chapter. I guess we'll get more into arrhythmias and stuff later on.
You know what? The new Ettinger has changed orders a little bit. And the chapters on abnormal heart sounds and murmurs and pulse alterations are now actually before syncope. So
I noticed that. Actually.
Yeah.
I thought we were skipping it because everyone here's done murmurs and knows how to measure a pulse. So
no, I think we probably won't go back because I'm just having a quick look through. There wasn't a huge amount of detail in there, given that the cardiology section is so detailed. So we might cover that stuff when we get to cardiology. But if people are interested, they're pretty short chapters and just have a quick read through to make sure that we're not missing anything. Cool.
cool.
Are we done with syncope?
We're done with syncope, I think. That's
Well done,
overview.
Josh.
So know the definitions, look for cardiogenic versus cardiogenic and neurocardiogenic.
Yep.
And differentiate it from non-cardiogenic.
Yeah. Good one.
Other causes of collapse. Yeah.
While we're on dyspnea, no, wait, while we're on definitions is what I'm trying to say. What define dyspnea?
Difficult breathing, labor breathing.
Yeah, exactly. So technically, dyspnea is something that a human would describe as having difficulty breathing or shortness of breath is what the sort of technical definition is. And obviously, because our patients don't self-report anything, we just extrapolate from that. So any evidence of increased effort to breathing is called dyspnea. What about tachypnoea?
It's increased respiratory rate with not necessarily an increased effort.
Exactly right, and should be differentiated from panting, which is not tachypnoea, but technically is tachypnoea. So no light bulb moments really in those definitions. What about orthopnea?
That's just a spectrum, isn't it? Like it's like really marked dyspnea.
I think it's a positional.
It's a position, yeah.
Yes, it's a positional definition. So dyspnea that is only present when a patient is not in sternal or upright recumbency. So this is, I like this definition because quite often I'm doing ultrasounds on patients and they look fine, particularly during an echo, they look fine when I'm examining them, listening to their heart. I lie them on their side and all of a sudden with that little bit of atelectasis squashing that downside lung, they just don't have capacity, they decompensate and they develop dyspnea. So it is a nice thing if you're doing a clinical exam on a patient that the owner sort of said, oh, a bit of it, exercise intolerance, lie them down for part of the exam and just keep an eye on how their breathing goes, whether they decompensate. Obviously, stress levels are going to compromise that as well. But if they're nice and calm and you reckon you can do it, it's a nice way to test the reserve of their breathing. So what is it that dictates how often we breathe and how deeply we breathe? How does the kind of, what components are there to that system?
The respiratory center of the brain is one.
Yep. And what speaks to the respiratory center? What peripheral sensory signals will we get to that respiratory center to say
from the muscles that involve respiration, like the diaphragm, intercostal muscles?
Sensory, what are they sensing that would then impact the respiratory center?
I think it's the carbon dioxide levels that are like your carbon dioxide in the blood.
Good, excellent. Yeah. So is it just carbon dioxide or oxygen too?
Oxygen too, I think. But
and what are those receptors called?
Chemoreceptors.
Good, exactly. So they detect levels of carbon dioxide and oxygen in the bloodstream. There's receptors centrally and there's receptors peripherally. So one does oxygen, one does carbon dioxide. Which one's which?
I think the carotid is oxygen and then the brain is the carbon dioxide. Is that right?
Yeah.
Other way around.
Are they around? Okay.
Unless I wrote it down. No, it is the other way around. Yeah. So CO2 is peripheral and oxygen is central.
Central. Okay.
Yeah. And at what level would we, at what level of carbon dioxide would we see dyspnea develop clinically?
I think greater than 50.
Very good. Yeah.
5, I think 55.
50, yeah. So greater than 50, we start to see an increase in rate, and then we see progressively increase in effort after that. So the body does not like the carbon dioxide to get greater than 50. What about oxygen? That's harder, I reckon. What SpO2 would you start to think, oh, this patient's going to start breathing up?
90?
90.
Yeah, perfect. I'm going to share my screen because we should always review the oxygen saturation curve. But I can't find it. There it is. Can you see this?
Yeah.
Can you see the oxygen saturation curve?
See the thumbnail of it.
Oh, that's not big enough. Let me go again. Oh, yes, gotcha. Now?
Yeah.
Yes.
Amazing. Can you also see my map?
With the map of Sydney.
Very important that you can see where we are. I don't know how to get rid of that, but at least it's big enough for you to see the oxygen thing now. Okay, so when we've got an SpO2 of 90, and this is something that we can really like anchor to clinically, right? Because we monitor SpO2 under anesthetic. We've got an SpO2 of 90, we've got a PaCO2, so PaO2 of 60-ish. Now, we remember this from uni, but it's very good to review it. This curve is an S shape. So above 90, the PaO2 doesn't change that much. Sorry. The SpO2 doesn't change that much. Once you get below 90, the amount of oxygen in the blood drops off precipitously. So if you go, so between 90 and 100, we've got 40, what's the unit of oxygen?
mmHg.
Mercury.
Millimeters of mercury. Yeah.
That's the one.
Yeah.
Create the pressure.
Yeah. So we've got 40 above 90, right? But if you go between 90 and 80, we go down by 15. If you go between 80 and 70, we go down by another 15. And if you get down to an SpO2 of 50, you've only got 25 millimeters of mercury in oxygen in your blood. So it's very important that we keep patients above 90 because every % drop signifies a very significant reduction in the amount of oxygen in the system. And that's when our brains will kick in, our central chemoreceptors will kick in and say we're sitting at less than 60. And we need to start increasing respiratory rate and effort to increase our oxygen levels. We talk about the respiratory center in the brain. So that's going to then send signals to where? Natalia's already said this.
To the muscles of respiration.
Yes, exactly. What are the muscles of respiration?
Diaphragm, abdominal muscles, intercostal muscles.
Excellent. Perfect. So what sort of diseases will we see dyspnea develop in? Obviously respiratory, but where can we localize disease to? Where might the disease be? This is a dumb question. Just list the respiratory system.
So, like body systems, you mean?
No, not body systems.
Where in the respiratory tract?
Sorry, where in the respiratory
Where
tract?
in the-
Exactly.
Like
So-
upper respiratory, lower respiratory, musculoskeletal, neurological.
Yes. Pleural space.
Pleural space. Excellent. Yes. So exactly right. So we should consider what I'm trying to get at. We should consider diseases that will affect those respiratory muscles in causes of dyspnea. So it might not technically be a respiratory disease. It might be a neuromuscular or neurological or muscular disease or metabolic disease that might affect the muscle function as well. Okay, so let's talk while we're kind of on the SpO2 train. What are the causes of hypoxemia?
What do you mean, like VQ mismatch, like those sort of things?
Good, excellent. Yeah. VQ mismatch.
Diffusion impairment.
Yes, excellent. What is that? What sort of diseases do we see diffusion impairment develop?
Can that be in things like bronchopneumonia, where the alveoli have got fluid in them, and we've got an impairment of the passage of oxygen and carbon dioxide between the two. Yeah.
Absolutely. So pretty much any disease where we get stuck in the alveoli, which creates a bit of a barrier between the gases and the vessels where those gases need to exchange, or interstitial disease, which again thickens that barrier between the blood vessels and the alveoli. What about, I want to go back to Pooja's VQ mismatch. What sort of diseases might we see that would impair oxygenation?
Pulmonary thromboembolism.
Great, I love it. Anything else?
Pulmonary edema.
Good.
Oh, talking about mismatch.
Yeah. So pretty much anything that will causes interstitial thickening is going to decrease perfusion of that area of the lung, isn't it?
Paraquat would that fit that definition?
Does that cause a
I think it's fibrosis.
edema?
Type 1 pneumocyte problems, I think.
I don't know, actually.
It's something I knew a lot about because the two examiners for the fellowship had both published on it, so I knew it extremely well. And I as well.
Yeah. Yeah, I'm not sure. I'd have to research it. Is paraquat used? Is this something that I should know about?
No, not in Australia for a long time.
Okay, all right.
Herbicide, but I don't think it's used here much. It was
Okay.
in rural England at the time,
Yeah, right.
which
Okay.
my time was a long time ago.
Good. Okay.
And what about volume overload? Would that fit in? Like volume overload?
To VQ mismatch? If we had volume overload to the point of I don't know how it would. Of venous congestion, maybe? No, because it's still the perfusion should still be the same. Unless we've got pulmonary edema, in which case we've got the barrier to gas exchange or diffusion barrier.
Well, going back to first principles, we've got a situation of one of two types. Either the lung is not filling with air, but it's still got a good blood supply, or the opposite, where the blood supply is shut down, but the lung's still filling with air.
Yeah.
Anyway.
So I think we'd get venous congestion for sure. But it wouldn't be until we got pulmonary edema that we'd get a mismatch potentially. Yeah, perfusion should still be all right until we get transference of that congestion through the capillary bed and into the artery.
What about just a dog lying on its side for too long?
Atelectasis, good, great. Under GA, a really important thing that we see all the time, right? What's another cause of hypoxemia that happens under GA?
Intubating one lung.
Great. So that's definitely a VQ mismatch. What about if somebody forgets to turn the oxygen on?
Oh,
That's not good.
No. No. What about if what I'm trying to get at is
You mean like the percentage of oxygen that's getting to
Yes,
the patient
that's
is
what I'm
impaired
getting
or
at.
something?
yes, decreased inspired oxygen concentration. It's pretty rare, but anesthetic's probably the time that it's going to happen.
yeah, okay.
Or at altitude.
Or at altitude, yeah. Fortunately, we're not seeing many
Very often for us.
most of our road's quite steep, but it's not.
We had that period at North Shore where the oxygen machine wasn't working, and we thought we had 100% oxygen coming out, and we didn't.
Yeah.
Wow,
Room
interesting.
air.
Work that out.
Oh god.
That would have been really confusing for, I imagine.
It was.
We ventilated a lot of patients as well. It was bad.
Yeah.
Give me some other categories of causes of hypoxemia. So we've got VQ mismatch, we've got diffusion impairment, we've got decreased inspired oxygen concentration.
You could have extreme exertion, like a seizure, I guess. Where you get extreme use.
Yes. So definitely a seizure. What about
Where do shunts fall in?
Mm.
They fall into VQ, right?
Nope.
Like cardiac shunts, or are you talking about?
Yeah, cardiac shunts, like
Yeah.
your right to left.
Yeah.
Right to left shunting. Excellent. That's great.
Okay, that's another category by itself.
That's another category on its own. Yeah. So why would a right to left shunt cause hypoxemia? Simple.
Skips the lungs, basically.
Skips the lungs. Yeah. They never blood never goes through the lungs. So we're getting completely unoxygenated blood dumping into the oxygenated blood on the left side of the chest. Back to bronze one, what I want to get at is rather than kind of a seizure or activity kind of thing, there's like a category of where animals just aren't breathing well. What is that called?
Or like decreased excursions or something like that. Like you
Oh,
said.
hyperventilation.
Yeah.
Oh,
Funny when it's like painfully obvious like that sometimes in your brain. Anyway.
Am I asking this question like sideways or what's going on?
It's just too early.
Yeah. Hypoventilation, exactly. And then there's one more category which is a little bit rare. What about if you've got like what causes this? What happens with methemoglobinemia?
yeah, so you can no longer carry oxygen on the hemoglobin.
There's nothing wrong.
All into the same category then, as in terms
Technically, causes of hypoxemia, it's one of the causes of hypoxemia. So if you think about the whole kind of pathway, you've got decreased inspired oxygen, so the air has lower oxygen concentration, and then you move into the upper airway and lower airway hypoventilation, and then you move into the interstitium and alveoli and say diffusion impairment, and then you move into the vessels and say VQ mismatch, and then you move into the heart and say right left shunt, and then you move into the bloodstream and say hemoglobin abnormality. Can we think of it like that, just as far as kind of trying to remember, like start in the environment? Causes of hypoxemia. I say this because it's like I would love to ask this in an exam. Like I think that's a really nice kind of way to make a candidate demonstrate that they understand how that kind of pathway works.
What about nitrite and cyanide poisonings?
I don't know how they work.
Nitrite causes methemoglobinemia.
Oh yeah, well in that case for sure, anything that causes methemoglobinemia for sure.
And cyanide, I've forgotten the mode of action, but it basically there's the blood's well oxygenated, but it's not absorbed.
They go blue, don't they?
It's some kind of binding affinity thing, I think, memory.
That's why it's called cyanide. I just have a light bulb moment.
I know.
Yeah, that's amazing. Or is it just a blue substance?
Oh yeah, cyan.
Yeah. Anyway, that's a mystery for the ages, and someone can research that. So there's kind of a lot of categories of causes of hypoxemia. What about causes of hypercarbia?
The most common one we'd see is hypoventilation.
Right.
And yeah, hypoventilation and excessive dead space in the anesthetic system.
There's still probably hypoventilation. It's just
Right.
not moving the air in and out properly. Yeah. The Pooja, say it again.
Oh,
Same category as in hypoxemia.
VQ
Yes, exactly. So if the CO2 in the bloodstream never gets to the alveoli or to that gas exchange surface, you're never going to blow off the CO2. So VQ mismatch is the other category, but they're the only two categories of hypercarbia, basically. Clinically, we see hypercarbia a lot more than we see hypoxemia because you take the precaution of having them on 100% oxygen when they're under GA most of the time. So we've got heaps of buffer without oxygen. With, you know, you can have mild impairments to all of these areas like hypoventilation, a little bit of atelectasis, blah, blah, blah. But because you've got them on 100% oxygen, it overcomes those barriers. Whereas hypercarbia, we require good ventilation to manage. And that's something that we just see a lot clinically. Other than anesthesia, what's the most common clinical cause of hypercarbia in our area, which for those who aren't in our area is the northern beaches of Sydney or North Shore of Sydney?
That will be tick paralysis, would it?
It's tick paralysis, exactly. Yeah.
I think some of the snake bites can do the same.
What was it?
Some of the snake bites, I think.
Yes. Yeah. So it's actually impairment of the respiratory muscle function from a neuromuscular perspective. So both snakes and ticks are the most common cause of hypercarbia that we see. Obviously, that's going to be quite specific to local things that you see. The only other thing that I really want to cover is I saw some cool radiographs, so I want to show you them. But I do want to do some videos like Josh of the different types of dyspnea that we see, because I think it can really help us clinically to localize where the problem is. So let me first share this radiograph because it's.
Ooh la la.
Oh,
The 1-year-old dog, just turned 1, presented with a very chronic history of dyspnea and exercise intolerance, and then acutely decompensated while out for a walk.
oh.
Tell me about these radiographs.
Crikey,
This so bully.
What would a cyst look like?
Thin wall.
They look like air-filled bulle, I'd say.
What's
that?
in a cyst?
Sorry,
What would be in a cyst?
fluid.
Well-
That would be fluid-filled.
Fluid filled, exactly. So radiographically, it would look a little different.
Yeah, it's interesting. It goes all the way up into the neck, so
Mm.
it looks like
It looks
it's
I actually think that's
hyperinflated as well.
yeah. Yes, very, yeah.
Yeah,
Actually-
like a really flat diaphragm, hyperinflated.
Very, yeah.
yeah.
Not a pneumo, which is interesting. Like, given the dog's acutely decompensated, I would have
Yeah.
expected there to be a big pneumo there.
Mm.
So this is a dog that has some sort of connective tissue disorder, and as a result of that has bullous emphysema.
Yeah.
But it's a really remarkable X-ray.
Mm.
Do you reckon, would that be, I mean, the heart looks so squished and small, would that be impairing the venous return as well and like affecting that cardiac function? Because it's so, I don't know, like you can barely even, I can't even see the caudal vena cava.
Yeah, you're right.
I would have thought it'd be really highlighted because of how much air is in there.
Airy. Yeah. Yeah, no, everything looks like it's
To their order.
very squashed down there. Other cases like this, so I did a bit of a literature search after seeing this. Other cases like this often have tension pneumos, and you see scalloping of the intercostal muscles on the DV. You see like the tension lines. and the diaphragm is pushed so flat because of the amount of tension in the thorax. And I can imagine in that situation, we get compression of the heart and cava, but this dog doesn't look like it's got a pneumo to me.
Did this dog,
Is this dog alive?
No.
did this dog have any other issues elsewhere in its body systems, like because it had a connective tissue issue? No.
No, not detected. So this is the single case reports through the literature like this. None, I've not seen any with such severe bullous change. They're all kind of smaller pockets, but most of them present with tension pneumothorax, and they're, because the radiograph, like prognostically, this dog, that's going to happen over and over again. It's not very fair to keep them going. But while we're talking about dyspnea, that's a very rare, unusual cause. So let's do, I did something silly. I closed my video window. Oh no. Oh no. Sorry. Coming.
I've got Ettinger open if you want me to do it.
Can you do it? That would be amazing.
Yeah. Which one did you want?
Let's start from the beginning. Obstructive. So some of these videos are pretty crap quality, actually. So what would we expect with an obstructive inspiratory breathing pattern?
Inspiratory noise.
Good. What's the noise?
Stertor.
Stertor.
Stertor or
Striders.
striders? Exactly. Yeah. And what's the respiratory rate going to be like?
Increased.
Increased?
Slight.
Might be slightly increased. What's the expiratory pattern going to be like? Big, deep breaths or short, sharp breaths?
Slow.
Low. Yeah, exactly. So that's what differentiates an obstructive from a restrictive pattern, is the depth or the respiratory muscle movement. So let's play this one and see what this dog looks like. So it's tricky with this dog, obviously stressed. Its respiratory rate's a lot higher than I would expect from a classic kind of obstructive respiratory pattern.
It's effort in and effort out as well.
Yeah, inspiratory and expiratory effort. And you can see the abdomen moving as well, the increased pressure in the abdomen. We see increased chest movements and an abdominal engagement in breathing when there's respiratory fatigue. So the respiratory muscles have run out of puff. They're relying more on movement of the abdomen to pull the diaphragm back rather than using the intercostal muscles. So this pulmonary fibrosis is a really restrictive disease. The lungs just don't expand. So let's have a look at the respiratory pattern on this one. Probably could have pulled it out from under the chair for the video, but. You can see the abdominal effort on expiration. You can see that the inspiration is a short, sharp. It's a very short breath. Can everyone appreciate that? As opposed to an upper respiratory obstruction where they take a huge kind of intake of air. And would we expect a pulmonary edema and pleural effusion? This is a little bit tricky, to be a obstructive or restrictive pattern.
Restrictive, I think.
Probably restrictive, yeah.
Or maybe even combination sometimes, because
it's not going to be that straightforward. Yeah.
We like tachypnoea with, I reckon, more restrictive. But
yeah.
Let's have a look.
Let's do it. Look at that abdominal movement. So much effort.
Call that an end expiratory push.
Mm. So I feel like we see that push quite commonly with pleural effusion. In fact, we see it quite commonly with a lot of diseases and upper respiratory obstruction as well. Last one. This is something we talk about in humans a lot, is a tracheal tug with increased respiratory effort. We don't really talk about it with animals, but I think it's a nice thing to look at the thoracic inlet and see how much negative pressure is being generated to draw air in. So it gives you a bit of an indication of how much effort. I think this is a remarkable comeback from this cat.
Yeah.
Oh, that's good. Respiratory distress is so heartbreaking. I just find it.
Isn't it? It's
hard to
so
watch.
awful. Yeah. All right. So we better wrap up there. If anybody's got anything else they want to cover or any extra questions, send them through for sure. The next one we're doing is movement disorders, tremors, ataxia, paresis, and paralysis. So just a short topic. And unfortunately, I can't offload to Josh because he can't make it next one. Someone let him have a holiday, unfortunately.
I've read a conference.
Oh, is it? Oh,
Okay.
okay.
In holiday. It's
In that case, you can come home and tell us everything. All right, so we will see you in a fortnight's time, and I think it's 4 or 5 chapters that we're covering. So everybody do your reading of the new book.
Cool.
Thanks,
Guys.
Josh.
Thanks, everyone.
Thank you guys.
Thank you.
Thank you.
Bye.
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 Thank you.